Hello everyone, I'm Dr. Preeti Singh from Pediatric Cardiology, Medanta, the Medicity, Gurgaon. A prospective observational study to assess accuracy of intraoperative epicardial echocardiography in assessment of surgical repair of ventricular septal defect. A significant proportion of major defects are now completely corrected in early infancy with improving rates of survival. Thus, there is need for intraoperative epicardial echocardiography and microtransosophageal echocardiogram probe, which can be used intraoperatively in small infants. TE is used as a standard in intraoperative echocardiography, but it has a few limitations and can cause procedural complications. And IEE might be simple but effective alternative to TEE. Epicardial echocardiography has a few advantages. In this study, we assessed the accuracy of IEE to detect residual lesion of ventricular septal defects and its impact on early surgical outcome. To determine this, IEE findings were compared with simultaneously RV2PA step-up in oxygen saturation intraoperatively. IEE findings were also compared to postoperative transthoracic echocardiography findings done within 24 hours of cardiac surgery. RB2PA step-up of oxygen saturation of greater than 7% was considered significant and suggestive of significant left to right shunt. We conducted this study because there is very limited data on accuracy of IEE in assessment of surgical repair of VSDs. This study was done in Medanta, the Medicity. All pediatric patients with VSD, either isolated VSD or VSD associated with other congenital heart disease undergoing cardiac surgery were included with a sample size of 85, and this study was prospective observational study. The data collected were age, gender, body weight, preoperative echocardiography findings, IEE findings of VSD repair, RV2PA step-up in oxygen saturation, intraoperatively post-surgical repair of VSD, surgical revision if done for VSD, postoperative transthoracic echocardiography findings done within 24 hours of surgery, and subsequent transthoracic echocardiography findings, redo surgery if done, early surgical outcome were the important data recorded. This is a epicardial IEE image done in Medanta, the Medicity. It shows an LV long axis view showing a VSD patch in a patient who underwent arterial switch surgery with VSD closure. P-value less than 0.05 was considered statistically significant. In results, male to female ratio in our study was 4:1. The weight ranged from 2.8 to 30.6 kg and majority were from 4.1 to 8 kg. The age group weight ranged from 1 to 84 months with majority less than equal to 6 months of age. The female and male population both had majority of the patients less than equal to 6 months of age. Majority of patients were acyanotic with 46, that is for 54%, and cyanotic were 39 patients. Maximum number of patients in our study had isolated VSD, that is VSD not associated with any other heart disease. The perimembranous VSD was present in maximum number of patients. Large VSD was seen in 79, moderate sized in 2, and small sized in 4 patients. VSD was closed by patch in 82 patients and direct closure was done in 3 patients. On final intraoperative echocardiography findings, no residual VSD was seen in 62 patients and insignificant residual VSD was seen in 23 patients. Insignificant residual VSDs in our study denotes VSD is less than 2 mm and hemodynamically insignificant VSD. Out of 85 patients, 3 patients required immediate revision of surgery. Out of these, only 1 patient required revision of surgery due to residual VSD. This patient was diagnosed with large perimembranous VSD with inlet and anterior extension. And this patient's postoperative course was good and discharged in stable condition. On TTE, done within 24 hours of cardiac surgery, no residual VSD was seen in 69 and insignificant residual VSD was seen in 16 patients. On subsequent TTE findings, no residual VSD was seen in 72, insignificant in 12, and LV2RA jet was seen in 1 patient. This LV2RA jet was missed on both intraoperative epicardial echocardiography and transthoracic echo done within 24 hours of cardiac surgery. Redo surgery was done in only 1 patient, but this was not due to residual VSD. Findings of IE were similar to interpretation of left to right shunt by RV to PA step up of oxygen saturation. After final cardiac surgery, no significant step-up was seen in all 85 patients, and TTE showed that 69 patients had no residual VSD and 16 patients had insignificant residual VSD. 15 patients were detected to have insignificant residual VSD as per both IEE and TTE findings. Sensitivity and specificity were 93.75% and 88.41% respectively. The positive predictive value was 65% and negative predictive value was 98.39%. Accuracy of intraoperative epicardial echocardiography was 89.41%. Immediate revision of surgery due to significant residual VSD was done only in one patient. This prevented later redo surgery and improved the postoperative outcome. No patient required redo surgery due to residual VSD. Death occurred in 5 patients and none of the deaths occurred due to residual VSD. There were no complications due to IEE like cardioversion and infection. Similar study was done by Manvi et al. With similar results. IEE thus has high accuracy in assessment of surgical repair of VSD. We missed one inlet VSD on the IE, and this may be due to quite posterior location of the VSD. Thus, IE is accurate and safe for intraoperative echocardiography in surgical repair of VSDs.
Thank you.
A couple of questions. One is who performed